All right, we're jumping right into a classic clinical mystery today. Imagine this. A patient's blood is way too acidic, and at the same time, their potassium has tanked to a dangerously low level. So, how do we crack this case? Let's break it down clue by clue.
So, you've got these two big problems staring you in the face. Too much acid, not enough potassium. But here's the key. These aren't two separate issues. No, they're actually two clues pointing to a single culprit. And our investigation starts right now.
You know, every good investigation kicks off with that first crucial piece of evidence. For us, that means we're heading straight to the urine to see what the kidneys are up to.
And our first tool is something called the urine anion gap, or UAG for short. You can think of it like an audit of the kidneys. See, when the body gets acidic, a healthy kidney should be working overtime, just furiously pumping out acid in the form of ammonium. The UAG is this really clever test that basically tells us, hey, are the kidneys actually doing their job or not?
Okay, so this brings us to our first major turning point in the case. We run the UAG test and the result comes back negative. What in the world does that tell us? Where's the real crime scene if it's not the kidney?
Well, a negative UAG is an incredibly powerful clue. It totally exonerates the kidneys. It tells us they're responding perfectly, dumping tons of acid just like they're supposed to. So, if the kidneys are innocent, the problem has to be somewhere else. And the number one culprit? The gut. We're talking about bicarbonate loss, usually from diarrhea. Case closed on the kidneys for now.
But what happens when that first clue points directly at our prime suspect? Let's see how this whole story changes.
So, let's rewind. We run the exact same test on a different patient, but this time, the result is positive. This flips our entire investigation on its head. Now, who does this finding accuse?
A positive UAG is the smoking gun. It proves the kidneys are failing to get rid of acid. Even though the rest of the body is screaming, we're too acidic, the kidneys just aren't fighting back. We've found our culprit. The problem is absolutely in the kidney. And this points us directly to a diagnosis of renal tubular acidosis, or RTA.
So, now that we have our main suspect, RTA, we can't just stop there. We've got to narrow it down. We need one more test to figure out exactly which type of RTA we're dealing with.
Okay, so we're pretty sure it's RTA, but the investigation isn't over. We really need to know which type it is, because the two main forms that cause low potassium have totally different things wrong with them. So how do we tell them apart?
It's actually pretty simple. We just check the urine pH. In type 1 RTA, the very last part of the kidney's plumbing, the distal tubule, is broken. It literally can't secrete acid, so the urine pH stays stubbornly high, above 5.5. But with type 2 RTA, the problem is earlier on. It's wasting bicarbonate. So once the blood bicarbonate levels get low enough, that final part of the kidney actually works fine, and the urine can become acidic, with a pH below 5.5.
Now let's really zoom in on that type 1 distal RTA. It is notorious for causing dangerously low potassium. But why? It's time to uncover the mechanism behind what I like to call the Great Potassium Heist. And the scene of this crime is a very specific cell, the type A intercalated cell, deep in the collecting duct. This little guy is supposed to be the kidney's acid-secreting powerhouse. But in type 1 RTA, its machinery is just fundamentally broken.
So here's how the heist unfolds, step by step. First, the main pumps that push acid out are busted. To keep the electrical charges in the urine balanced, the kidney is forced to dump potassium instead of acid. It's a trade-off. Second, to make matters worse, the pumps that are supposed to pull potassium back into the body are also broken, so that potassium is just trapped and lost in the urine. And third, the final blow. The body is losing salt, which triggers the hormone aldosterone. Aldosterone basically screams at the kidney to save sodium at all costs, and the price for saving that sodium is to dump even more potassium. It is the absolute perfect storm for potassium loss.
So you see, what starts out as this really confusing mix of symptoms actually becomes a very solvable case. By just following the clues in order, first the urine anion gap and then the urine pH, we can pinpoint the exact problem, from the entire body all the way down to a specific broken pump inside a single kidney cell.
You know, this whole case really shines a light on the kidney's true role. It's not just some passive filter, it's the master chemist of the body, constantly fine-tuning our entire internal environment. This diagnostic trail just goes to show you that when even one tiny piece of its machinery fails, the consequences ripple through our entire system. It really makes you appreciate just how vital that delicate, incredible balancing act truly is.